Hi, I'm Glenn Gardner, the Director of Maternal Fetal Medicine here at the Mater Mothers Hospital. Today I'm talking about antenatal testing for fetal abnormalities. It's wise to consider fetal abnormalities in 3 different categories, and this helps with talking to patients and helping them understand what type of testing is available. Those categories are simply chromosome abnormalities, structural abnormalities, and gene or genetic abnormalities. Chromosomal abnormalities are the common types of things that testing is used for example, trisomy 21. Chromosomal abnormalities also include newer findings like microdeletions and microduplications. With respect to structural abnormalities, they're the things that we will see most commonly at the morphology scan at 20 weeks gestation, things like cardiac abnormalities and spina bifida. Finally, there are the genetic abnormalities, which testing is becoming more available for. Conditions like cystic fibrosis, for example. It's important to consider whether a fetal abnormality risk is hereditary or, if it has occurred in the past, whether it's what we call de novo, occurring for the first time. Most cases of trisomy 21 occur as de novo, in other words, occurring for the first time in the pregnancy. In about 10% of children with trisomy 21, the parents may carry a balanced translocation, or there may be a family history. With structural abnormalities, there may be a risk of recurrence, an increased risk of recurrence over the background risk, and that depends on the particular abnormality. For example, neural tube defects and cardiac abnormalities have a small increased risk of recurrence in a subsequent pregnancy, but it doesn't follow the standard hereditary type risk like autosomal dominant inheritance or autosomal recessive inheritance. If there has been a previous history of a fetal abnormality, it is worth considering a referral to Queensland Genetics Health or to Maternal Fetal Medicine to consider what is the risk of recurrence and what is the best approach to testing in the current pregnancy. When you are seeing a woman for the first time in early pregnancy, it's important to assess their knowledge of the things that we're talking about, because some will come from a place of a good understanding, particularly if they've had a previous affected pregnancy, but many will have very limited knowledge or understanding of not only the conditions that we're testing for or potentially testing for, but also their understanding of the tests and things like screening versus diagnosis. It's important to provide information that is relevant to their level of understanding and in different forms. For example, written information. Sometimes that might be best in a language that is not English. It's important to document what information is provided and their response. It's also important to document if any tests were offered and their response. One of the more recent tests that's become available for women to consider, both in early pregnancy and even when they're not pregnant, is whether they carry a recessive gene. The common recessive conditions that are relevant include cystic fibrosis, Fragile X, and spinal muscular atrophy. There are many other recessive conditions, and there are some that are relevant for specific ethnic groups, such as Tay-Sachs disease in Ashkenazi Jewish people. Now, in Queensland or across Australia, there is available now a test, and with most pathology providers, a test for common recessive conditions. The one that we offer at the Mater is called Prepare, and it offers testing for CF, SMA, and Fragile X. Usually we perform that test in the mother, and if the mother demonstrates to have one of those genes, then we test the father. If both parents carry a recessive gene, then there is a 1 in 4 chance that their offspring will be affected in any future pregnancy. You only need to do this test once, because if a patient doesn't have a recessive gene, that's it for life. They're covered. It's always important to cover the pros and cons, benefits and risks of any testing. Of course, many people will consider whether they will continue the pregnancy with the diagnosis of a serious fetal abnormality. But not all parents make that decision, and some will use the testing for preparation for a child with special needs. It's also important to identify an at-risk fetus because it may be possible to offer antenatal intervention that can alter the outcome for the pregnancy. For example, in utero treatment for spina bifida. Another option, of course, for some parents who choose to continue the pregnancy for children that have lethal abnormalities is the preparation with palliative care. Many women will experience some anxiety and will be reassured by most of the testing that is available. The cost of testing has become a very relevant issue because many of the tests now are not completely funded by either Medicare, state health funds, nor hospitals. And it's an important point of discussion to make sure that patients aren't sent away and then get faced with a bill that they weren't expecting. It's always important for patients to try and grasp the concept of screening versus diagnosis. NIPT, or non-invasive prenatal testing, has a 99% detection rate for Down syndrome, but it's still only a screening test. And that's because it's not actually testing the fetal chromosomes. It's doing a fancy calculation based on placental DNA. If a NIPT test shows a high-risk result, it still requires diagnostic confirmation with an invasive test. A 20-week morphology scan screens for many structural abnormalities, but can also be a diagnostic test, for example, in the diagnosis of spina bifida. Other tests like CVS and amniocentesis are the more traditional diagnostic tests that we employ, where screening tests are positive. Just as a summary, this slide shows screening tests that are currently in use, including NIPT, first trimester combined screen, second trimester triple test, and a morphology scan. Diagnostic tests include chorionic villus sampling, amniocentesis, tertiary morphology scan, and also fetal MR or MRI. Just to remind you that a CVS is a sample of the placenta taken via a needle, usually transabdominally, but in about 10% of cases we may adopt a transcervical approach. The risks for both CVS and amniocentesis have recently been revised and are much safer than have been previously published. Recently, a large study reported the procedure-related risks of amniocentesis and transabdominal CVS to be much lower than what we have previously been quoting. The risks now we quote for amniocentesis and CVS are the same, and we believe the most accurate figure is somewhere between 1 in 500 and 1 in 1,000 procedures for both amniocentesis and transabdominal CVS. For transvaginal or transcervical CVS, the risk is harder to define, and we quote between 1 in 100 and 1 in 200 procedures as the procedure-related risk. So to compare, the screening tests in this table shows the detection rate and the screen positive rate or false positive rate for each test. And you can see the dramatic improvement in screening performance being offered for Trisomy 21 on the basis of a NIPT test, with a 99% detection rate and a less than 1% screen positive or false positive rate. This compares with the most common test prior to NIPT, which was the combined first trimester screen, which offered an 85 to 90% detection rate for a 5% screen positive rate. With respect to termination of pregnancy in Queensland, there was law reform in 2018 decriminalising termination. Conscientious objectors must still refer, and each state and territory in Australia has laws that differ with respect to termination of pregnancy. There is a guideline, the Queensland Maternity and Neonatal Clinical Guideline, if you want more information. The MATA does not and never has offered elective termination of pregnancy services, and patients requesting termination of pregnancy may access public or private services such as the Queensland Health Hospital or Murray Stopes. The first trimester combined screen is still a valid and effective screening test for major chromosome abnormalities like the common trisomies. The benefits of a combined first trimester screen are also that the woman gets to see her baby on ultrasound, and also you have the opportunity to make a diagnosis or at least suspicion of a severe structural abnormality very early. The detection rate for Down syndrome is about 9 out of 10, or around 90%, with a combined first trimester screen. That can be improved by using NIPT to 99%, however, you lose the advantage of the early anatomical assessment. The results of a combined first trimester screen, which combines PAP-A and beta-HCG with a nuchal translucency scan, should always be combined, hence why it's called that, because if you offer two separate risks, it can be very confusing for the patient. Other issues to consider with the first trimester combined screen are that if the nuchal translucency is increased, 3.5 millimeters or more, there may be a risk of a cardiac malformation. If there is a low PAP-A, less than 0.4 multiples of the median, we recommend review of those patients at 24 weeks through maternal fetal medicine, because there is an increased risk of preeclampsia and fetal growth restriction. The triple test is really falling out of favour, and very few are ordered these days, and that's because of its low detection rate and relatively high screen positive rate of 5%. However, it still remains a valid screening option that is often performed for patients who present late, too late for the first trimester combined screen, and also for a cost-effective option that has better performance than the morphology scan for trisomy 21. A recent development in chromosome testing has been utilising a chromosomal microarray test compared to conventional karyotyping, and this has opened up a huge array of particular anomalies related to deletions and duplications. Sometimes, however, those deletions and duplications may be variants of unknown significance, which can create a lot of anxiety, and we would usually refer such patients to a genetics expert to discuss and investigate further. There are benefits, however, with microarray testing, and hence why we've adopted it, and that's an improved detection of existing anomalies over conventional techniques. This chap, Dennis Lowe, in 1997 first reported free fetal DNA in the maternal circulation. He was studying cancer DNA, in fact, and thought maybe the placenta might be acting a bit like a tumour and invading the maternal circulation. And he was correct in that DNA from the placenta is present in a pregnant woman's blood. And it's important to note that we call it fetal DNA, but it is in fact placental DNA. And in some cases, the placenta may have a chromosome abnormality, but the fetus may not. Hence the need for a diagnostic test if an NIPT test shows a high-risk result. Just as a way of background, sometimes I always get asked about fetal cells. Remember, free fetal DNA, or the NIPT test, is not fetal cells. Many patients, and I think many doctors, believe that this is about a cellular-based test. It's not. So fetal cells have been studied for many years. NIPT is fragments of DNA. So this is cell-free. And the big difference is that cells may persist in a mother's circulation or engraft into the maternal system after each pregnancy, whereas free fetal DNA is cleared after every pregnancy. There's never going to be any confusion about testing fetal DNA in the maternal circulation. The clinical applications of NIPT continue to grow. Apart from the potential misuse for gender identification, it has been used for rhesus and other blood group typing of the fetus, and more recently the detection, or at least the screening, for chromosome abnormalities, and also extended into testing for deletions. What about NIPT for microdeletions? At the moment, this testing is not endorsed by our College of Obstetricians, and neither is it endorsed by any overseas genetics nor obstetric body. This is because validation has not yet reported proof of principle with respect to detection rates, sensitivity, specificity, and positive predictive value. At the moment, we do not support microdeletion testing via NIPT. That may change in the future as more information is gained about the false positive rates and detection rates. What are some of the problems of NIPT in practice? Well, certainly you can get false positive results and they can be very distressing. Usually they're sorted out with invasive testing. You can also get false negative results, and unfortunately they're rare. If there is a no-call result, then that has been shown to be associated with a higher risk of chromosome abnormality. In such cases, we offer invasive testing and recommend that you refer any no-call results through to maternal fetal medicine. Usually a no-call result will be repeated at no charge by the pathology provider before clarifying that it is a true no-call result. Sometimes placental mosaicism exists where there are different cell lines within the placenta, some normal and some chromosomally abnormal, but the fetus may be chromosomally normal. Placental mosaicism really can upset NIPT testing. It can give you a positive NIPT, but the fetus may be normal. This can be sorted out by doing an amniocentesis. What about the routine morphology scan? This has been the mainstay of screening for many years now, and it's usually performed at 20 weeks gestation. It's important that patients understand, and certainly in our department we inform them that we do not have 100% detection of all abnormalities. For example, for cardiac abnormalities, it's around 20 to 75%. Neural tube defects, it's very good at more than 90% detection. Cleft lip and palate, more than 75% will be detected. Trisomies 21, only 20 to 50% detection, but it's very good for trisomies 13 and 18 with more than 90% detection. Sometimes patients may inquire about 3D and 4D ultrasound. There are places offering pleasure scans, so just imaging the baby for pleasure. These places do not offer scanning for medical reasons, and we have had some issues with patients thinking that their scan that they've had at one of these pleasure 3D places is a real scan, a medical scan. The reality is that 3D and 4D ultrasound hasn't really changed dramatically our ability to detect fetal abnormalities antenatally. There are still people looking for the place of 3D and 4D ultrasound, but at the moment we use it for surface anatomical abnormalities, such as cleft lip, to show to the parents in as best of ability that we can what the abnormality looks like. When should 3D and 4D ultrasound be used in pregnancy? We believe that for keepsake imaging it has a very limited role, but that's its most common use at the moment. And in general it's not enhanced. So in general, fetal anomaly detection is not enhanced by 3D and 4D ultrasound. So let's move on to our case study. Mary is a 36-year-old, gravida 3 para 1. She's had a previous term baby born 3 years ago. She has no medical or family history of note. Her BMI is raised at 36 and she's at 12 weeks gestation. When you see her, let's review what options she has for prenatal testing. So with respect to the first trimester combined screen, the benefits of that are that there is good detection for common trisomies. There is also the ability to have a structural assessment of the fetus. There are still some issues with respect to accessing this test in the community, and there are out-of-pocket costs that the patients have to incur often. Importantly, for the MATA, for patients that have difficulty paying, for refugee, Indigenous and other vulnerable women, we offer testing with the first trimester combined screen at no charge through the Mater Mothers Ultrasound for Women. What about NIPT? Well, apart from the cost, and the cost varies, but it is around $400 to $450. It's a very good test for trisomy 21. It has a very high detection rate. However, it will miss major structural abnormalities that are usually seen at the 12 to 13 week time, and it has a limited range of abnormalities that it tests for. So the jury is out still as to which is the best test for women to access, and first trimester combined screen remains the mainstay of testing for the majority of women. Some women are certainly having both tests, but are having to obviously pay for that. One of the questions that always comes up is, what is the place of NIPT with a first trimester combined screen? Should it be done before or after? Often it is done before a first trimester combined screen, and if it is done before that, then at the first trimester combined screen, risk assessment for trisomy 21 is not required. One of the benefits of having the early scan still at 12 or 13 weeks is that an anatomical assessment of the fetus can still be undertaken. You can still diagnose twins, and the woman, of course, gets to see the fetus. If a woman has had a combined first trimester screen and is high risk, then the question may be asked, should I have an NIPT instead of amniocentesis or CVS? One of the problems with NIPT in this context is that the very limited range of conditions that it's testing for, largely the common trisomies and sex chromosome abnormalities. If a woman has a high-risk combined first trimester screen, in the first instance we will offer them CVS or amniocentesis with microarray testing. That will give them the largest range of conditions covered for that risk. The other thing to consider is the cost. Certainly, on top of spending for a combined first trimester screen, they'll have to fork out another $400 to have NIPT. One of the benefits of amniocentesis is that we can offer microarray testing, which has opened up the range of conditions available for testing hugely. The risks from amniocentesis, as I discussed previously, have also come down. So what are the messages I want you to take home after the presentation? It's important that you inform and offer screening and diagnostic tests for fetal abnormality to all pregnant women, not just those of, for example, advanced maternal age. NIPT is the best screening test for trisomy 21. However, it does have some limitations with the number of conditions that it is screening for. The first trimester combined screen offers additional useful information compared to NIPT alone, such as early anatomy assessment. The triple test remains a valid option and a low-cost option for late presenters. NIPT, first trimester combined screen, and the triple test are better screening tests for trisomy 21 than using maternal age alone or the 20-week morphology scan. If ordering NIPT before first trimester combined screen, further risk assessment for trisomy 21 is not required. If having a first trimester combined screen, remember to refer those cases that have a nuchal more than 3.5 millimeters for separate cardiac assessment, and those cases that have a Pape less than 0.4 multiples of the median, who will have further assessment because of an increased risk of preeclampsia and fetal growth restriction. Nowadays, it's always important to offer carrier screening to all women, either contemplating pregnancy or in early pregnancy, for at least common recessive conditions that include CF, SMA, and Fragile X. What's on the horizon? One of the more recent developments is to follow in the steps of Professor Newnham, who developed the Whole 9 Months program in WA, which aims to reduce the rate of preterm birth. We are undertaking cervical length screening at our hospital within the next 6 months for all patients booked at Mater. This involves a cervical length scan and the offer of progesterone should the cervix be found to be short. We are also embarking on a trial for first trimester screening for early onset severe preeclampsia. You'll hear about both of these projects in due course. Thanks for your time.